Good afternoon, everyone. My name is Jen Tracy, and I am the Chief Program Officer at RIZE Massachusetts Foundation. Welcome today, and thank you for coming to the webinar, Harm Reduction in Shelter Settings, Current Practices and Future Opportunities. Before we introduce the agenda of today's webinar, I'd like to take a minute to tell you a little bit about RIZE. Launched in 2017, we are a public-private partnership solely dedicated to funding and creating solutions to end the overdose crisis. Guided by those with lived and living experience and unafraid of new ideas, RIZE builds networks, designs programming, and supports community partners who are using novel approaches to preventing overdose. Since our launch, we have committed over $20 million to organizations across Massachusetts. Our network is made up of a constantly evolving and growing group of providers, community leaders, researchers, advocates, and people with lived and living experience who are equity-minded, collaborative, and determined in the pursuit of our mission. The recent decline in overdose fatalities brings us hope. However, the numbers remain all too alarmingly high. We believe that strategic investments in the workforce and research are essential to equip professionals such as those of you who are with us today, harm reductionists, shelter workers, with the tools and resources that you need to effectively support clients facing opioid use disorder, regardless of who they are or where they live. Next slide. A few housekeeping and tech-related items to note to start. So the webinar will be recorded. All audience members will be muted and off camera throughout the program. As you're doing now, thank you. We welcome all of you to introduce yourself and engage with your fellow audience members through the chat function. But please note, we will only be able to answer questions that come through the Q&A box, which is a different box than the chat if you see the screen. We will be conducting a Q&A session after our panel discussion. And if you see a question in the question and answer box that you want answered or that resonates with you, please feel free to upvote it by giving it a thumbs up. The recording of this webinar will also be available to view on our website and our YouTube channel following the event. Next slide, please. Now, to get into the context of today's webinar, harm reduction, as defined by the National Harm Reduction Coalition, is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Harm reduction is also a movement for social justice, built on a belief in and a respect for the rights of people who use drugs. At RIZE, we believe harm reduction is a key component in the substance use care continuum. Next slide, please. Today's webinar will focus on the exploration of harm reduction, specifically in shelter settings. Overdose is the leading cause of death among people experiencing homelessness. Harm reduction practices, including naloxone distribution and syringe access, can decrease the mortality and morbidity associated with high-risk substance use. However, currently, these practices vary widely from one shelter to another. We are understanding the obstacles and the opportunities for harm reduction opportunities in shelters, as well as identifying new practices inside shelter settings, is key to preventing overdose deaths. To better understand current harm reduction practices in shelter settings and uncover future opportunities, we partnered with the Regan Center for Addiction at Boston Medical Center to investigate harm reduction in shelters and speak with those most affected. Next slide, please. Okay, so for today's program, I will briefly introduce our speakers, followed by the presentation of the shelter study findings. You will then hear from a panel of experts who will share their insights and engage in a discussion about the results. Each panelist offers a unique perspective based on their experience, and we are so grateful to have them here today. At the conclusion of the panel, you will have the opportunity to ask your questions during the Q&A segment. We are excited and honored to be joined today by several respected collaborators and contributors to harm reduction in shelter spaces. I will introduce each of our speakers briefly, and you will hear more from them directly later on. Next slide, please. First, I have the pleasure of introducing the researchers leading this project, Dr. Avik Chatterjee and Tom Regan, joining us from Gregan Center at Boston Medical Center. Dr. Chatterjee is a primary care and addiction medicine physician at Boston Healthcare for the Homeless Program and Boston Medical Center. Tom Regan was a research assistant at BMC during the study and currently joins us from the West Coast, serving as the Coordinated Entry Systems Manager for the King County Regional Homelessness Authority in Seattle. Next slide, please. So we're also delighted to welcome Dr. Mattie Castiel, the Commissioner of Health and Human Services for the City of Worcester, as our panel moderator. Having collaborated with Mattie on the Governor's Opioid Recovery and Remediation Fund Advisory Council, I can confidently say that her dedication to harm reduction, treatment, and recovery initiatives is truly inspiring. It's a privilege to have you, Dr. Castiel, here with us today, and I look forward to an engaging and insightful discussion. Finally, I'm excited to introduce you to our three panelists. We are joined today by Mario Chaparro, Director of Low Threshold Housing in Boston at Eliot Community Human Services, Desiree Demos, Executive Director of the EVA Center, and Gregory Grays-Thomas, Director of Homeless Services at the Boston Public Health Commission. Next slide, please. So we'll also be live tweeting during the webinar. We welcome you to engage with us on X by following @RizeMass and using the hashtag harm reduction in shelters. So with that, I am so pleased to get started and turn it over to Dr. Chatterjee and Tom, who will present their research findings. Over to you, Tom.
Thank you. Thank you so much, Jen. Yes, hi everyone, and thanks everyone for saying hi and sharing your name and where you're joining us from in the chat. It's so exciting and great to see all the different organizations and all the different areas from Massachusetts represented. So real excited to be here and learning with you and sharing with you all today. Like Jen said, my name's Tom Regan. I joined Dr. Chatterjee working on this study when I was a MPH student at the Boston University School of Public Health. A little bit about myself, my background. So I started working in syringe access programs here in Seattle, Washington, although I'm originally from Salem, Massachusetts. Grew up there, moved out here to the West Coast, and then have experience working in permanent supportive housing settings and emergency shelter settings. And so that's kind of a little bit about my background and experience that brought me to the research we're going to share with you today. So the name of our project, it has a little bit of a colorful name. It was a quote that came from one of our participants' key informants. So the name of our project is "This Tough Love Shit is Just Not Love." And when I had shared this in the past, I had sought to kind of, tone down the expletive in the name there, and was encouraged by peers and colleagues in the field of qualitative research to say, do justice to the fact that this is the real data. This was the real words of the participants with whom I was speaking. So, but yes, it was a qualitative exploration of harm reduction in Massachusetts homeless shelters. Next slide, please. So a quick agenda that we're going to be going through today, talking about the research and the findings. We'll go quickly over the objectives of the study, the background and the theory grounding the work. We'll talk about our sampling and recruitment methods. After that, we'll talk about the interviews and the demographic data. And then I'll hand it over to Dr. Chatterjee, to Avik, to talk with you all about the key findings, and then to review some of the key findings of our toolkit that we developed. Yeah. Next slide, please. So the objectives of the study were really to describe the attitudes toward harm reduction practices that staff people, leadership, and guests had staying at 4 different shelter projects in Massachusetts. We wanted to understand their attitudes toward those towards those harm reduction practices, and we wanted to understand kind of which harm reduction practices were actually being used. Like Jen mentioned in the introduction, there is no kind of standard of care, for how to implement harm reduction in emergency shelter settings. And so we collected data in 4 different locations in Boston, in Salem, Massachusetts, in Lowell, and in Worcester. Some of our other objectives were to prioritize and elevate the voices of lived experience through our sampling and recruitment methods. We also had a team of peer consultants that worked with Dr. Chatterjee and I on, reviewing the study materials, making sure that they were reflecting the attitudes and beliefs and kind of knowledge of the community of peers and people who use drugs. And we were able to, thanks to the support of RIZE, pay these folks for their work with us on the study. The last objective that we had for this was to develop actionable recommendations for folks like you all. We really wanted the results of this work to have some key findings that folks would be able to take and use and put into practice immediately. Next slide, please. So as a background, these are data points and facts that we're all in this room very well familiar with. More than 100,000 people died from a drug overdose in the United States in 2023. And drug overdose is the leading cause of death for people experiencing homelessness. Harm reduction, as Jen said, is a set of clinical practices aimed at reducing the negative impacts of drug use. And like I just said a moment ago, though, while we know that harm reduction saves lives and has kind of gained popularity, I mean, for me personally, even standing here and looking at the chat and seeing, all these different shelter programs or different programs, for people experiencing homelessness throughout the Commonwealth, and seeing titles like harm reduction manager, that's so wonderful. And even just a few years ago, something that didn't exist. And so we're making great strides, but still, access to these interventions and conversations like this still, don't happen quite enough. So that's also part of our the background. Next slide, please. We grounded our research in the social ecological model. The social ecological model, or the SEM, it's a broad, multi-level conceptualization of health, really one that seeks to move away from our kind of Western United States view of health, that you can improve the people's health or the health of the population through kind of talking with folks about their individual choices. The social ecological model is really a foundational model that says that actually, wait a minute, we don't live in vacuums. There's an individual level, there's my relationships, there's how I interact with the community, and there's societal and systemic factors at play too when it comes to health. And so the social ecological model emphasizes those levels rather than just a focus on people's individual actions and choices. Next slide. For our sampling and recruitment methods, we used convenience sampling, facility-based sampling, and snowball sampling. So how this looks like is really I, as the primary research worker, would go to the 4 different shelter locations that we had, that those organizations had generously agreed to work with us and have me come. I'd set up an engagement table. I'd go to Dunks and get some donuts, coffee. I get gift cards for the participants who would agree to participate in the study, and I'd talk with them about the study, what we were trying to learn about, the types of things that I'd want to be chatting with them about. And then I would do interviews with folks. And so in total, we had 55 total participants. 40 of those were guests at the 4 different locations, and then 15 staff people. So some of those were, we had a good array of entry level or like direct service line staff, floor staff, case managers, and we also had different levels of leadership participate in the study as well. Next slide. So all the interviews took place at the different shelter sites, and all of the interviews were done using a BMC provided recording device, and they took place in the most private settings that the shelter allowed. So I'm sure this audience is well aware, sometimes it can be a little bit hard to find privacy in a shelter setting, but I just again want to shout out teams of those different sites for being so accommodating to me, letting me use offices, you know, letting me borrow a key for the day so that I could, you know, key in and out of those spaces and do these interviews. So that's how the interviews took place in the different shelter settings. Next slide, please. Here is a table of the demographics for both the shelter guests and the staff and leadership that we worked with. So for guests, as you can see, the mean age is around 48. There was a good wide range there too. The youngest folks we talked to were 25 years old, and some of the folks on the older end were 73. When you look at the gender demographics and the sexual orientation, as well as the race and ethnicity, you'll see that a lot of folks chose not to answer those questions. And so that kind of skews the data a little bit. That said, the data is still, you know, fairly representative of the cohort of folks that I spoke with, although I could say anecdotally, just from, you know, my physical observation of being there, that, you know, you see 45% of the guests that I spoke to, and according to the table, were women. One of the shelters that I collected data at served only women or female identifying folks. There was another program that I collected data at that only served male identifying folks or men. And so there were some more men that I spoke with. There are also, you know, when you look at the race and ethnicity demographics down there at the bottom, many folks chose not to answer. But there also was a broader array of representation that I noticed from my, again, kind of anecdotal experience being there and talking with the people, with folks of color. However, like I said, many folks chose kind of to say, I'd really like this to be as private as possible, would like to give as little information as possible, so they chose not to answer those questions. Next slide. So now I'll turn it over to Avik, to Dr. Chatterjee, to talk with you all about the key findings from the study.
Thank you so much, Tom and Jen and everyone, all of our panelists and everyone for being here. I actually know some of you from my work primarily on the Healing Community Study over at BMC and across the state, but a lot of you I don't, but I'm very, very happy that you all were able to join. One quick anecdote about what helped me want to do this study is that I see patients at various shelter-based clinics across Boston through Boston Healthcare for the Homeless program, and I just remember seeing on actually numerous occasions, but in one day in particular, folks who had gotten syringes for safe use from one of the local syringe service programs, but because the shelter did not allow syringes or other substance use related paraphernalia, the person was looking for a spot under a rock to hide their needles before they entered the shelter, with the hopes that they'd be available for that person, you know, again the next morning. So this sort of cognitive dissonance of the system offering these resources, but then other parts of the system not supporting that, and trying to sort of dig deeper into what was going on and why, as far as harm reduction practices in shelters. Okay, so next slide. So what I'm going to do is I'm going to summarize. Tom had mentioned the theoretical model that drove our how we analyze our findings. Basically, things that harm reduction practices and shelter-related harm reduction sort of constraints at the individual, interpersonal, organizational, and then societal level. So I'll go through an example theme at each of those levels, and then we're actually going to go to our toolkit and our key findings that we think are going to be actionable for you all at the sites where you work. So one of the individual level themes that came up was that the state of homelessness in particular lent an additional level of chaotic nature to substance use patterns and lack of safety. So this is one of our guests who shared that. So everybody in the shelter bathrooms will hang out and smoke a cigarette or whatever. The other night, my friend was in the bathroom. He keeled over. He was fine for all intents and purposes, just high. Then the staff came in, and I can't tell you how many times I was like, listen, I'm just trying to wake him up, but I'm not leaving him here alone, because then in the morning when he's waking up, he'll say, you left me alone. All my shit got stolen, you know. So that's a story we hear a lot in the shelter. And again, the homelessness piece, I think, adds to this level of lack of safety for individuals and chaotic nature of use. Next slide, please. So one of the themes we learned about at the interpersonal level was that sharing space with other individuals in the shelter setting was a cause of stress. So, but you're living in a shelter and it's like, what the fuck? Because you're living in the shelter, you know people, you make friends or whatever, but they're really not your fucking friends. But anyway, it's hard. So next slide. So at the organizational level, one of the themes that came up was that there was concern around communication, even if there were harm reduction strategies that were implemented. So even when naloxone, for example, was available in shelters, guests reported not knowing about its presence in the building, citing a lack of clear communication about naloxone and its availability. So in this quote, basically the interviewer is talking to this person, and the interviewer, because we've interviewed staff as well, we know that there's naloxone available for people who are staying in the shelter. But the interviewer asks, can you tell me about the supplies that are available here? And then specifically asks, do they give out Narcan? And the guest says no, even though we know that that's the case. So this lack of communication around harm reduction practices that even are in place. So next slide. And then issues at the societal level that constrain and ultimately harm patients. So prohibitory and stigmatizing policies don't stop people from using drugs in or outside of the shelter, but do make people less safe by influencing them to use in high-risk situations. So in this instance, the person says, I had a friend overdose. We were in South Bay. There's these stairs you can go up in the parking lot levels, and it's open all night. The security guard was like, don't come back again. And when he was over, my friend did his shot first quickly, and his head was going down. We were halfway up a flight of stairs, and before you know it, he dropped straight down, and his head cracked open. He wasn't breathing. I didn't have Narcan, so I briefly searched through this bag underneath him, but I couldn't get to it. So in this case, the prohibitory nature and having to use in a very, what seems like a very unsafe and unsupported space led to an unsafe and an unfortunate and preventable outcome. Okay, next slide. So we have our toolkit. So we had the themes that we elicited from our interviews. And then we also were able to sort of collect a list of things that shelters were doing, a list of things that some of the sites were doing, maybe not all, and then a list of things that guests and staff proposed as potential future directions. And so I'll start with the list of things that people felt that we found were happening across all 4 sites that we interviewed. So naloxone was available to staff and guests. The sites had either reverse motion detectors or, when not available, a bathroom checking plan. So people knew that bathrooms were places of high risk for overdose and use, and had some sort of plan or technology in place to detect overdoses there. First aid supplies, safer sex supplies, and some sort of additional bed policy for severe weather events, or amnesty policy allowing previously barred individuals to stay during severe weather events. So next, the list of practices that are partially or inconsistently implemented. So first, wound care supplies specifically for skin and soft tissue infections related to injection. Next, safe use supplies such as syringes and or bleach kits, fentanyl test strips, informational pamphlets for drug user health and safe injection practices. Next, a bad date list. So a list of individuals who may pose a threat to those impacted by the sex trade. Next, full naloxone emergency response kits with supplies for rescue breathing. As many of you know, naloxone is key, so Narcan is key, but also key and something that can keep people alive and people's brain healthy is being able to provide them oxygen respiration. So having things like ambu bags, etc., or face guards for breathing. Then no curfew policy. So this was, again, partially, but not at all of our sites, basically allowing folks to come in and out. As many of you know, especially in this fentanyl era, people may experience withdrawal and cravings to use sooner than the overnight period. So the idea of not having a curfew and having people be allowed to come and go was supportive of people who use drugs and keeping them in the shelter. So a no questions asked locker policy. Again, we talked about this idea of syringes and paraphernalia. policies encouraging guests to take breaks rather than barring them outright, and then alternatives to confiscating people's drugs if they are found on site. And then finally, the list of things that were proposed but are not currently implemented, at least at the sites that we were at. So complete offerings of safe use equipment, including syringes, works, pipes, et cetera, to promote drug use or health. Secondly, safer spaces to use, whether in the shelter or not. And then third, drug testing kits to test for drug purity, the presence of research chemicals or contaminants such as xylazine and fentanyl test strips, et cetera. Okay, so next slide. So I'll go through some of the major highlighted practices that we think folks, if you aren't already practicing, would be relatively easy to approach. So first is making the naloxone available to staff and guests with training for its use, and also then the specialized equipment for performing rescue breaths. And I think someone in the chat actually also called that out, and that's actually been one of the really exciting things to see evolve in the response teams around the Mass Cast area, Southampton Street, where I work and have been over the last 10 years, to really see the Boston Public Health Commission and the other outreach teams become really good at the rescue breathing piece, having oxygen available at all times for a response, and that's a really key strategy. Next slide. And then next is the reverse motion detectors, or a bathroom check system. So many of you may have the bathroom check system. The reverse motion detection systems are less, I think, less widespread. However, can be really nice because it offloads staff responsibilities as far as the timers and things you might be implementing. The other thing I'll say is that we talked to a program out west for a separate project that basically it was a day program, but they weren't allowing guests to use the bathroom. So imagine you're someone experiencing homelessness, someone who uses drugs, you go to an outreach site, but you're not allowed to use the bathroom because they didn't have anything in place to prevent overdose. Once they implemented a reverse motion detection system, staff then felt comfortable letting people use the bathroom. And so it sort of like unlocked a lot of things and support for folks and improved engagement, just having that in place for safety. All right, next slide. Okay, so first aid, wound care, and safer sex supplies. So expanding, and then in some cases, needing to partner with organizations that do a lot of wound care. A lot of you, I know, looking at the names and the organizations you're with, do wound care, but is that true for all the shelters where you all are? So for shelter providers, potentially partnering with the orgs that are doing the wound care, that can be such a key engagement tool for people who use drugs, keeping them in shelters, let's say, when they might not necessarily want to be, and have access to then other services. Next slide. And the bad date list. And that's something I think that, was something that, and again, you could say look into lists of things that we have, that a lot of those are things that you may have known about already, but this was something that came up that was, for me, a newer finding, and I think really powerful, in that a lot of this was driven by the people who we spoke to, that is the guests in the shelter themselves, that this was so helpful for them to have. Okay, next slide. Okay, and then no curfew policy. So this is something that that I think several places are doing. I want to call out the Friends floor and Gregory, who's going to be speaking later, as well as part of the panel. But that it's been such a game changer for folks, because this supports not only like what we talked about as far as the chaotic use patterns, that it might not be that a person is going to use from 9 to 5 and then stop using, and stay in the shelter overnight, but it allows them the ability to come in and out of the shelter and then have a safe place to be when they're not using. The other thing it helps too is it helps with things like doctor's appointments, with work schedules that may not match with the timing for when beds are available. So I think for a lot of patients, it's been really life changing and supportive. No curfew policy. Okay, next slide. And then this idea of opening additional beds and temporarily allowing folks to come back into shelter, even if they were previously barred for, let's say, violence or substance-related behavior during severe weather events, which I think supports the safety and health of folks who we work with. Next slide. And then don't confiscate people's drugs if they're found on site. I'm going to defer to a lot of you in the questions and answers and the panelists around the practical nature of how you implement something like this and some of these other ones. But in some ways, this might overlap with the idea of the no questions asked locker policy, where whatever folks are using and having and have put resources into getting, or the supplies which keep them safe, letting them store that, even that's that's something that you don't want in the shelter itself. Next slide. Great. So that's really our key findings, some of the themes, and then how those translated into practical tips for shelter providers and for you all. So what we're going to have now is I'll let Jen introduce our panelists, but they're going to answer a few questions that we had pre-specified around our findings and our toolkit, and then we will open it up for broader questions.
So thank you, Tom and Avik. That was wonderful. It was a pleasure to hear you guys. We have an amazing panel here, and I would love for them to introduce themselves. I'm going to start with Desiree. She can introduce herself.
Hi, everybody. My name is Desiree Demos. I currently am the executive director of the EVA Center, but for the purposes of this project and for the last few years, I actually had worked at Harbor, which is a harm reduction shelter in Worcester, Massachusetts. I was open from 2020 to 2023 before new leadership changed the direction of the organization. During that time period, in multiple roles, I oversaw the daily operations of Harbor and kind of informed best practices around harm reduction and created policy, person-centered policy and procedure. Harbor is a shelter that was open specifically for women who are being commercially sexually exploited on the streets of Worcester with active substance use disorder, and historically speaking, have been barred from shelters with lots of hoops to jump through to get in there. Thank you. It's great to be here.
Thank you, Desiree. Greg, how can you introduce yourself?
Hi, everyone. Good afternoon. I'm Gregory Grays-Thomas. I'm the Bureau Director for Homeless Services at Boston Public Health Commission. Related to this panel, Homeless Services has one low threshold site that caters to people who are in active addiction. I've mentioned it, the French floor at our men's shelter at 112 Southampton Street, and we had one previous at 727 Mass Ave. So we have quite a bit of experience serving this population. And personally, I've worked with Homeless Services for about a little under 20 years now. God, I'm old, but nice to be speaking with you all.
Thank you, Greg. Mario.
Hello, everyone. My name is Mario Chaparro. I am the program director for the low threshold housing within Boston for Eliot Community Health Services. Previously, I worked for Bay Cove Human Services at the Casper Men's Residential Program, where I implemented a lot of harm reduction models within the residential programs. And previously to that, I was actually the program director for a low threshold program with the City of Boston, the Engagement Center. And yeah, I've done a lot of work in harm reduction, and I'm also a person in long-term recovery, and I'm here to give my input.
Thank you, Mario. So I'm going to start with some questions for the panel. So we'll start with Greg, and I'll tell you the question. So what are your initial reactions to the findings, and did anything that they said surprise you? And were any of the findings encouraging or discouraging? And Greg, could you start?
Yes, definitely. I'd say my initial reactions, I didn't see anything that was surprising to me, but certainly discouraging was seeing the comment about the person who didn't know what resources were available. Because, we spend a lot of time implementing practices, building systems, trying to make sure that everything that we do is with the lens of, making sure that shelter is accessible to everyone, including our active users. And so then if people aren't aware of the services that you are providing, then what are you doing? And so just wanting to make sure that we have, awareness of what is available inside of the building, the services that we offer, and making sure that everyone actually, more so than just understanding that they're available, but actually utilizes those services and supports is something that's obviously very important. Having Narcan all throughout your building is nice, but if people don't know it's there in an emergency, and I'm sure everyone on this call and this here can attest that there's never enough Narcan around when you really need it if it's not right on your person. And so just it's not enough just to have these things. You have to make sure that people are aware and know how to access them at the same time. And so that was a nice, sobering reminder for me. I think we lost your sound.
You can't hear me?
But now we,
Now we can. Oops.
Oh, sorry. I was going to Mario, wondering what he thought, and he's just staring at me. I said, what
Well,
happened?
I couldn't hear, and I thought so, and I was gonna try to chime in, but I was like, is she? Yeah. So I mean, I'm gonna kind of ditto what Greg said. What was surprising to me was the fact that they were saying within the study that Narcan was not readily available. I find that to be kind of confusing because everywhere I go, everyone is actually asking for Narcan to give out, or there's Narcan pretty much I walk on Mass and Cass and see Narcans on the building, on the sidewalk, like you see Narcan everywhere. So to me, that was surprising.
Desiree?
I too was going to go with Narcan, but I'm going to switch it up a little bit because we already did that. I was surprised also. We can get everywhere within reach, right? But I think that I was thinking a lot about that in the last couple days, and I think that might have something to do. There was a time period during this research project where it was really hard to get your hands on bulk Narcan. I don't know exactly the time frame, but I know that we struggled with it. So did the other shelters in Worcester, to the point where we actually Harbor became a Narcan distribution site so that we could get Narcan. And then we went and got approval to then give out bulk Narcan to other shelters. I know there's actually people in the chat that I've seen that were able to benefit that. So that helped us. We always had Narcan. We always gave it to people when they left. Hey, do you need Narcan? Oh no, I'm not using it. Okay, that's cool, but you might save a life today, so just take it anyway. So I think that probably contributed. Was that time period. And I'm surprised that people are still throwing away people's drugs and paraphernalia. I just want to remind people that the things that people have to go through to get those things, you're almost like doubling up on their trauma, right? For our women, especially if they had to trade access to their body for that, and then you throw it out. What do you do now? It's not like they're going to stop doing drugs because you took it, right? So now they have to again go, and is that the time that they're going to die? Are they going to be beaten to like a near-death experience? And then outside of even the population I serve, even for others, they're engaging in criminal activity for that, right? Boosting, stealing, things like that. So now they're going to go have to commit another crime, and now maybe they're incarcerated, and now that's just creating barriers later to like employment and housing and things like that. So I would like to see maybe some other people kind of take a hold of that and look at other solutions than taking those things away.
Thank you. I appreciate that. So what are some practical and policy barriers to the harm reduction measures discussed in the findings? And in your experience, which is the most challenging to implement? Who wants to start? Desiree, you want to start?
Yeah.
You're there.
I think being able to legally give people syringes would be the most helpful out of everything, right? Because right now it's kind of like this like backroom handoff because we're doing it. You know what I mean? It's important because can I direct somebody to a needle exchange? Can I, send them somewhere I know they're going to be able to get needles? Yes, absolutely. But if they are sick and with withdrawal, are they going to get on a bus and go travel halfway across the city to get a needle? Like, absolutely not. And, speaking from experience as a person who, was so high out of my mind, one time I needed a needle. I went to a shooting gallery and was convinced that I found my own needle that I had stashed there, when the reality is that that's not accurate. I'm always going to give out syringes. And if there's legal recourse later, then I'm going to take that as probably the lowest charge I've ever gotten in my life. Right. So I think that it would be really nice if we were just able to do that.
It is sad that people do go to syringe exchange, get their clean syringes, and then go to the shelter and they can't use it and have to find a place to put it. Greg, what's your thoughts?
I'd say for us, the most practical barrier that was mentioned in the findings has actually been the curfew piece. And so our shelters are large scale, they're designed for the masses. And as everyone on this call knows, we are in shelter crises. All shelters across the state are at an overcapacity. And so at a time where that's the case, to be able to say, oh, this person who I don't know is coming back to this bed, but at the same time, there's a physical person here before us who we know does need this bed, has been an actual challenge for us. So being able to sort of find that balance between the need of a person to be able to come and go and still access a safe and stable space while respecting the other person who maybe went to work all day and is coming back to find, maybe there is or isn't a bed available, has been definitely a challenge for us logistically to make sure that our active users can access the space successfully.
Thank you, Greg. Mario, what are your thoughts?
Well, within the shelter space, I would definitely agree that taking away someone's drugs after after having to hustle all day and really try to get yourself to feel better, because that's what it really is. Like, people will say that they don't really understand why they're doing what they're doing, but in reality, like, there's a lot of pain, there's a lot of misfortune that is going into someone literally trying to get themselves to feel better because they have nothing or no one. So for us to literally be punitive, because that's what I feel like it is, right? Like they're already being caught in the street. They've been abused. They've been, whether it be physically, emotionally, verbally, and then to come into a place where you think is going to be safe and you can't bring what you work so hard to get, and knowing like the next day you might just have to wake up sick, or you have to sleep out on the street because you don't want to wake up sick. I feel like there's a lot of changes that need to happen in that area right there.
I think you're right, Mario, and that's probably one of the reasons that people don't go into shelters, as you said. So I think that's incredibly important. Thank you. Each of you has participated in harm reduction innovations at your respective institutions. Reflecting on the practices presented, what are some strategies to overcome resistance and to build support for harm reduction practices? Mario, since you're here, what do you think?
For me, harm reduction is it should be a way of life for anyone who works in this field. And I say that because it's not just harm reduction shouldn't just be a policy. It shouldn't just be something where we need to initiate it. Like, I feel like harm reduction just needs to be a part of what we're doing in the field that we work in, because we're not people who just sit behind a desk, right, or a cash register and hand out money and change. We're dealing with human beings' lives, and we're dealing with emotions, and we're dealing with so much trauma. So for us to just sit back and think of harm reduction just as something where we need to implement into a strategy or a program or something bigger. But for me, it should be a way of life. Like, we're talking about people's lives here. We're talking about how do we help someone overcome tragedies, overcome obstacles and difficulties within their mental, physical, emotional status. And then we just think of it as, something where I'm trying to explain it in a way where I'm not so, mean about it, but like, I just feel like we need to do better as a whole, as a community, as people. Like, for me, I'm a person in long-term recovery. I said that in my intro. With that being said, there's been times, like, I've stayed at the Southampton shelter. I've stayed in the Worcester shelter. I've stayed in many shelters throughout Massachusetts. I've been in many programs throughout Massachusetts. And one thing I can literally say is that I felt very much alone in these places, because I felt like people who worked there did not understand me or did not want to help me. So with that being said, I feel like we owe it to our communities, we owe it to the people who are suffering, to not just make harm reduction a model, but to make it a part of what we do.
Wholeheartedly agree with you. Greg, what are your thoughts?
Yeah, I think actually one of the most successful strategies touches on something that Mario mentioned, and it's that idea that people don't necessarily know you or sympathize with what you're going through and feeling seen. And one of our most successful, excuse me, strategies has been sort of recontextualizing the humanity of our guests and that these are real people who are standing before you. And so even our staff or someone or another guest who's maybe the most resistant to harm reduction, what they do understand is their friend, or they do understand that person who's there with them, who they have worked with every day or see every day. And so even if on paper, the idea of harm reduction is a challenge, what people will understand is, hey, here is Gregory, and you know Gregory, and these are the things that he needs. How do we make sure that Gregory is safe, for example? You know, those are the things that people really understand. They understand the person before them. And so even if a person is maybe resistant to some of the ideas around harm reduction, we've been able to really turn around a lot of attitudes and really get a lot of helpful practices in place by just reminding people that this is a real person and these are not just fancy ideas on a page. This is really an end, a means to an end to make sure that people are alive and healthy and have access to the service they need to, end homelessness and maybe navigate to recovery one day. And so it really starts with that sort of person to person connection we found.
To you, one more question. Where have you seen the greatest successes in implementing harm reduction measures?
For me,
Mhm.
I would say our,
Go ahead, I'm sorry.
yeah, I think our, some of the success we've had in implementing harm reduction measures, I mean, quite a few. I mean, definitely things like having, policies that allow people to come and go, like I mentioned, as a challenge, but it's definitely been one of our major successes for the shelter. And being able to see a person who is maybe still living with addiction, but still gets up and goes to work every day is only enabled because we have those sorts of policies and, just that sort of empowerment of a person to do the things that us, that we do every day, being able to decide when you wake up and decide when you leave the building and what hours work for you in terms of being able to find employment. Those have all been really key indicators for success for us because on paper, do we have a lot of people who have been navigated to recovery? Maybe less than I would hope, but we have a lot of people who are doing things like engaging now in services, who are going to employment a lot more than I think that we would have anticipated. And so I think a lot of our traditional metrics, we were thinking like, oh, navigation to treatment, et cetera. But our successes have really been about getting people out into the world and really finding themselves again, which has been nice to see.
Thank you. Desiree, I'm going to go to the next question with you, if that's okay.
Let's do it.
How do you manage the tension between offering harm reduction measures for people who use drugs in the shelter with the sentiment from others where it is, guests or staff that these measures may be triggering to people and their recovery?
I don't think that harm reduction space is the best place for people in recovery, but there's ways to navigate that, right? Harm reduction should be for the people that need it most. We should be able to prioritize people and have our value system in place for people that are actively using substances. By taking somebody in recovery and putting them in that space, we're making them more vulnerable to relapse. One of the things that I would recommend, and you got to really stand your ground on these things, is that when you get calls from we call them case dumps, right? When you get a call from a case manager at a facility and they have somebody getting, discharged from CSS and they need to get them a bed. Well, you're not going to get them a bed here because this isn't the place for them to go. So you really have to push people to kind of go above and beyond. Okay. Cause I know that you just want to check the box. Not everybody, there's some great people out there, right? But you're looking to check a box. You're looking to get them into a bed, and I'm looking for you to get them to the right fit for them. The next thing that's going to get them where they need to be. And so I'm going to challenge people to go ahead and try that. But at the end of the day, I'm never going to somebody coming to our shelter when they have nowhere to go. So generally it's like, hi, try these things first. If not, and you feel, or your organization or your facility can discharge people to the streets, please feel free to do that. And this is our address, and they can come check in. And having kind of first come, first serve policies helps with that too, because they actually need you to say, yes, this person can have this bed on Friday. So by having kind of policies that make it harder for them to discharge you, makes them have to level up and put the work in, right? And then if they do end up with you, I'm going to let them know instantly, this is not the place for you. And so we're going to work really hard to get you to where you need to be. And if they're not struggling with substance use disorder and they're not having kind of the chaos that goes around that, then they're going to wake up the next day and we're going to go to it. And now they didn't find you where you needed to go, but I'm going to find you. And maybe it's a sober house, but maybe you didn't have funds but we're going to look for that. And we're going to do it together. And we're going to get people who deserve to be in recovery spaces and recovery spaces. Likewise for staff, that is always going to be a trigger. I like to tell people when we hire them, I like to have like a real conversation like, hey, if you're struggling, if this is too much, it is nothing on you. This is a hard space to work in. And I want you to come talk to me. And I want you to tell me that, because, you know, there's other positions within our organization that aren't right here in harm reduction. You know, you don't have these things right in your face. You're not finding needles on the ground. And if this isn't it, then I know plenty of jobs out in recovery, you know, so having a real conversation with the staff and having a relationship with them where they feel like they can tell you that is really important in this work.
Wonderful. That's great. Thank you. Mario, are there practical methods to foster a welcoming and safe environment for both staff and clients?
I do believe so. I do believe it starts with education and support. I believe if we can educate our staff and our clients on like what harm reduction really is and how we can support our staff and our clients. So, for example, when I was the program director at the men's residential program, we've had a lot of people, a lot of men relapse, and a lot of other men who are really working hard on their recovery come up to us and say, hey, like, you know, so-and-so is not doing well. And when we sit down and we talk to them and we support them, they let us know how they're feeling. And I think that's what it is. I think we need to have a broader conversation on how people are feeling, instead of just like, okay, we're just going to keep him without an explanation, or we're going to discharge him without an explanation. I feel like everybody needs to have those conversations so that people understand, especially the people who work in this field, understand how other people are feeling within the realm of the community that you're working with.
And for all of you, I'm going to ask, if you had a magic wand, what would be a policy or funded related game changer that could change the landscape for people experiencing homelessness and using drugs? And with that, I'll also add, what would be your ideal shelter? What would that look like? Greg, you want to start?
Sure. I think if I had a magic wand, obviously money is nice. But I think to that end, I think some of the things that we could do with that sort of money is really just expand on the work that's already happening. And so, you know, the study that Avik and Tom presented on, you know, gave this toolkit of practices that almost every provider can do in some level. They are really practical suggestions and solutions. And a lot of times it's really just about having infrastructure support and funding to do those things. And so I know for us, if I could wave a wand, I'd really just expand on that low threshold work that we're doing, create buildings dedicated to low threshold substance use programming where we can provide the on-site clinical monitoring and, you know, controversial, I know, but like safer use space that's incorporated somehow within that element, because it's just a critical need, and you know, and you can't really accommodate that in a setting like ours, for example, you know, where you do need to cater to everyone. As Desiree mentioned, harm reduction spaces can be really dangerous for a person in recovery, and so you know, you have to keep all of those things in mind. And so being able to have separate and dedicated spaces and services is just really important, and being able to have those resources to carve that out explicitly, I think would be wonderful.
Thoughts, and also what is that magic wand, but also your thoughts about the ideal shelter? What would that be like?
Is that me?
Mm-hmm.
That's right. My magic wand would be that we could get housing for all the people that are in shelter that don't need to be there and could actually, you know, be self-sufficient in housing. Because the reality is most of our shelter beds are often held up, not just in harm reduction, but just throughout our shelter system in general, right? There's plenty of people in there that are perfectly capable of having their own housing, and we need as many available beds as we can have for the people that aren't. So that would be my magic housing wand. What was the second part, Mattie?
What would your ideal shelter look like?
Well, it was Harbor. It was beautiful. It's a place of community. I think that Harbor really was doing things right. It was a lot of trial and error to get where we were, but it was a community of staff with lived experience and survivors that really had no problem talking to each other about anything. You know, we prioritize the population that we serve, similar to DV shelters prioritize DV victims, and we prioritize sexually exploited women with substance use disorder. And that made for a great relationship with the people in our program and our staff. And when it came to harm reduction, they were willing to talk to us about anything. We need everything that they needed in the moment, right? Did they get pregnant by a sex buyer? They're going to tell us about it, right? Is there some bad dope on the street right now? We're going to hear about it. We're going to tell other people. Do they have wounds that need to be taken care of that they refuse to go get treated like crap at the hospital for? We're going to take care of it there. We don't care if you're still shooting up in that same spot, right? I think that Harbor was really doing some good work and had a great community of survivors and staff with lived experience. And I would actually like to see that replicated. And if anybody on the call has tons of money and wants it replicated, let me know. I'll be there to help.
I agree, Desiree, and we miss it here in Worcester too.
Get it back.
Mario, what do you think? And also to answer the question, but also even add, what do you think of congregate versus non-congregate?
Congregate versus non-congregate. I think that we should have a little bit of both, to be honest. I don't think either or. Again, for me, it's how we need to meet people where they are. So some people may want a congregate setting and some people may not. And I feel like we should be able to provide those type of options when it comes to dealing with the population in the community that we work with. If I had a magic wand, I would literally get rid of stigma because I feel like stigma plays a big part in why this whole, like, even these panels and these discussions, why we're having these discussions, why we have to, you know, literally talk about what's best for human lives that are suffering. And I feel like stigma plays a big part in that. And I feel like if I had a magic wand, that would be the first thing I get rid of, is the stigma against substance use and mental health. And my shelter setting would look honestly like a family setting. I would want it to be like a family setting, regardless of like if people use drugs. For me, I have substance use in my family, right? Does that mean that I don't want to be around my family during the holidays, during you know, Christmas and Thanksgiving and birthdays? Like, no, like regardless if they're active or not active, like that's still my family. And I feel like if we can make shelters that way, like we'd have a better place.
Agree. So I'm going to go back to one of the questions that I skipped, just because I wasn't sure if we had enough time, but we're doing well. So are there any specific populations that you have focused on in your work? And please explain how you have tailored harm reduction measures to meet the needs of those populations. And I'll start with Desiree.
Actually, we're going to skip Desiree, because what happened was when you skipped that question, I used some of the stuff from that question to answer the other question.
Okay.
Next.
Next, Mario.
So I'll go with like a specific population for me would be monolingual Latinos. And I say that because you know, growing up as a young kid, my mother never spoke English, and me having to like translate for her in hospitals was something that I always did for her. But when I look at, you know, our monolingual population that come in for services that really don't understand the services that we're offering, or they don't even know what harm reduction really is. They, you know, I've spoken to people and they say, oh, wow, yeah, you're just really nice. And it's like, no, that's harm reduction. Like, that's what we need to do. Like, oh, no one else does that. So to me, like that's the population I would want to serve, to educate them more, because I feel like that's a problem, and I feel like we could do better.
Greg, what are your thoughts?
We've done a lot of work around working with people who are more unsheltered oriented, so people who are more traditionally street based. I see that Liliana Ruiz was in the group. Shout out to her from at St. Francis House, now formerly of VPHC Homeless Services. And that team did so much work at our 727 site with not just integrating active user space, but also making a person who had been sleeping outside in a tent for years feel comfortable and safe in a building. Working with people to even go from, actually, I know that we have this courtyard here for you, but this is actually for smoking. Let's get you into your bed. That's a huge thing, to take a person who's traditionally living in that sort of space and in that environment, to make them feel safe enough to want to keep coming back and to want to get acclimated to sleeping in a bed and want to get, accustomed to talking to social teams and case managers every day. It was just a lot of work, and the teams have done a lot of really fantastic work to move that forward and get folks out from the streets and into our shelters, which has been really nice.
And lastly, I'm just going to ask, since we're closing just the panel, your words of wisdom that people can take home. Desiree.
You're a surprise question there, Mattie.
Yeah, I did.
Wisdom is to always everything person-centered. It's never going to be black and white. Everything in this work is in the gray area. Find folks with lived experience who are okay working in that gray area, and hold people who have a duty with their credentials to do the right thing for the people in their programs to like raise the bar and do those things, and just always put people first. I always tell my staff, I learned this from the founder of Living in Freedom Together, and I pass it on to my staff, that EVA Center, do what's right for the person standing in front of you in the moment, and we can always worry about whether it was the right or the wrong thing later.
Thank you. Greg?
For me, I would just say, it's not anything new for anyone on this call, but just keep doing the work. There's the work of harm reduction is truly to keep people alive and keep people here, so you can have another conversation with them tomorrow, and just to not lose sight of that. It gets challenging, it gets frustrating, but at the end of the day, this is just about the person who's in front of you and the people who you work with and live with and love, and just want to support and want to see flourish and grow. And so just keep that in mind, and just, there's a person behind all of these strategies who really, we just want to be here tomorrow and make sure that they're with us. And so, just keep that in mind. And as you talk with your teams, make sure that, the person is really just centered in all of these things.
Can you hear
Yeah. For me, I would just say, do amongst others as you want done to you.
Yeah, you guys were incredibly amazing. I've learned tons from all of you. And I'm going to turn it over to Jen, because I see that there's a ton of questions. So, Jen?
There are, thank you so much. Oh my goodness. All right. Thank you to both Dr. Chatterjee and Tom for your research findings, and for developing the tips and pointers in the harm reduction toolkit that was developed from your research findings, which we will share after this. And of course, to the panel, Dr. Castiel and Greg, Mario, and Desiree. It's so amazing, because all of the questions that were coming in, the panelists, while you guys were on the panel, Avik and Tom were answering, and I think we can sort of go back with a couple of them, because they've answered all the questions. But there's some different perspectives too that we can put in. So I really appreciate us being able to sort of read the questions, and now we can take a minute to discuss. Just to reiterate, if people have questions, they need to go in that sort of double Q&A box, not the chat, but there's good conversation happening in the chat. The folks that are on this webinar are a community unto themselves, and I hope that if you don't know people that you see in the chat, that you will reach out to them if they're in your area also, because we have both local and state and New England folks as part of this webinar, so really appreciate that. A couple of the themes within the questions, though, that I will sort of maybe pose. One is, Donna White, who, very well-known addiction nurse in Massachusetts and Boston. Thank you for your questions. I'll sort of speak for you since the members of the audience can't speak, but she was really sort of pointing out sort of this tension between people working in the space who might be in recovery themselves and implementing harm reduction strategies and sort of struggling with that within their own sort of work and maybe personal experience. And I know you touched on it in the panel, but I'm wondering if we could say a little bit more. I'm going to first go, all three of our panelists have this experience, I know, because I know all of your work, but I'll go to Greg first. I know that, doing the Friends floor, you've had this sort of real-time experience over the last couple of years, and then of course 727 of really implementing these harm reduction strategies within the setting and sort of having to balance how you support your staff that might be in recovery who are learning also, and how you support the people that you're serving. If you want to just speak a little bit to that, thank you.
No, yeah, it's a great question. And someone who works with us often mentions, especially to people who are in recovery, that they just have to make sure that they're separating their recovery journey from their work. And sometimes people intermingle the two. And so, it gets really challenging working with someone in active addiction. It can be very triggering. And so if you are very early in that process for yourself, this may not be the setting for you to work in, and being able to acknowledge that is not a bad thing. It's just a truth. We have very difficult jobs, and our clients, some of them have very difficult lives. We have very difficult lives in a lot of cases, our staff. And so it's not a cop-out to be able to acknowledge those limitations first and foremost. And then I would also add to that, training and education is just a really big piece of that, understanding that harm reduction and treatment are not the same thing. And that, yes, we hopefully can get people to navigate eventually into recovery and into treatment, but that's not necessarily what the priority of the day is. Again, the priority is to make sure this person is alive here so that maybe tomorrow you can have a treatment conversation with them. But you can't do that if they, overdose in the bathroom tonight. You have to be able to keep those things in mind. And so it is definitely a very delicate act. And a lot of it is just sort of making sure people have that time, space, that you're offering wellness activities so that people have someone they can talk to. We have trauma clinicians that our team can check in with after an overdose or after a traumatic event. All of those things are just really critical, especially in a space like this, where you really do need the lived experience of your staff to really make sure that the space is as integrated and healthy and holistic as possible.
Great. Thank you so much, Greg. Appreciate that. And I don't know, Desiree, do you have anything to add from your experience, or?
I agree with a lot of what Greg said. I know that for us, we open up an affinity space, which is for people with lived experience to come together to kind of be able to process the work that we're doing, like amongst each other, which I thought was really great. Also, when it came to certain things like at the shelter, right? Like if you found drugs, well, we didn't take people's drugs. If we found a bag of crack on the ground, we're not going to go around asking whose it is. That one's got to go. You know what I mean? So, something like getting another, like you're not picking it up by yourself. You're getting the other staff person on. You're doing it together. Things that kind of minimize that. I also think that boundaries are super important in this work. Everybody knows how important boundaries are, right? Not having participants on your Facebook, not talking to them outside of work, not giving that, giving them rides unless that's part of your outreach job. Like, do you know what I mean? Like just things that kind of minimize interactions. Like in situations where it might be harder to say no because you're not like right there on site.
Great. Great, thank you. Also, I see sort of Neil, some conversation with Neil around stimulant use and accommodating, people within the shelter settings, which oftentimes can be very hectic themselves and busy. So Avik, thank you for mentioning sobering centers and mentioning observation spaces. Did you want to add anything, Avik?
Yeah, I just wanted to highlight that because the folks who have championed sobering centers on the West Coast and elsewhere, they have really good data that it avoids ED visits and ambulance calls, right? Because if someone shows up to the shelter, if you have a space there, and honestly, Roundhouse, for those of you who know about that, the basement space there, it offered some beds where folks could do that. The SPOT program, which is still in place at Healthcare for the Homeless, allows for this. I think heavily oriented toward people who use opioids. So there's ability to monitor vital signs, give oxygen. But the limitation of SPOT, and I, work at Healthcare for the Homeless. I love the folks who set it up, is that it's only open like 8 to 5 or whatever it is, maybe a little bit longer. And it's not at the shelters, right? So those of us who are in the shelters in the evening, as people come in and are intoxicated, that's sort of where we need these spaces. So being able to support, and it's different things that different people will need, right? If they're overamped on stimulants, like Neil mentioned, the kind of space and support they're going to need is different than someone who's on opioids and might need a little bit of supplemental oxygen to keep them away from the hospital, which is going to be very traumatizing. And so I think investing in this idea of a sobering space for people who may be intoxicated, alcohol, opioids, stimulants, whatever it might be, on site, right? Rather than utilizing just kicking people into the street, which obviously we've all seen, and also not having to call the ambulance would be hugely beneficial. So it's definitely a future thing to look to as well.
One
Great.
thing that I want to add to that too is just this is more in like the permanent supportive housing type of setting rather than like an emergency shelter setting. Although I think that it's something that could be done in an emergency shelter setting, is like seeing if you can get donations of like old used desktop computers or electronics from the community. And I think that one thing that I've found in my experience is that like when folks use stimulants, they might kind of get into like tinkering with things, and then that can kind of turn to like maybe they're tinkering and like dismantling pieces of like the actual shelter space, so like going into the bathroom and like taking things apart. And so like a harm reduction strategy that I have seen and seen success with is offering folks things that it's okay if you like tinker and take this thing apart. Like here's like this old computer and it doesn't, I'd rather you kind of like tinker with this rather than going into the bathroom and taking apart all like the soap dispensers and taking the doors off the wall, like that kind of stuff.
As someone with amphetamine use disorder, that is awesome. That is a great idea, because the amount of things I've taken apart is probably not for all these people here, but I'm thinking about alarm clocks, just hand it to them, say the feds might be in this, and then boom, they're good for a couple hours in their own little space. That is accurate, and I love that. I do.
This is great. Thank you so much. Thanks, Tom. Okay, so there was Tom and Avik, I know you wrote a response to the question why Western Mass was not included in the study. If you wanted to just kind of share with that, I think that is always, geographical distribution about our research and attention and resources is something that we're thinking a lot about with our Mosaic partnership with the settlement dollars and how to distribute those across the state. But as part of the study, if you or Tom wanted to sort of address that, how the shelters were chosen for this study.
Yeah, I would say that we cast a wide net of who we reached out to work with us. I also think too that, and just to give credit again to the programs that did, that allowed me to come in and like collect this research. I think as someone who has worked in shelter environments and run a shelter, it's a risky thing and can feel like a vulnerable thing to say, oh, geez, this research assistant's going to come in and they're going to talk to people and that can just feel like a vulnerable thing. And so I think that like organizationally vulnerable. And I think that what we experienced was we tried really hard And that was something that when I started working with Avik from the beginning, that he was saying, we want to get geographic diversity. We want to get, I also remember folks from RIZE, in early conversations about this work saying, hey, how are we getting, west of 128? Like we need to kind of get some geographic diversity in here. And it was just hard to, when I talked to programs, sometimes they weren't as interested in having me come in and ask their guests and staff these types of questions. And so we wanted to respect that. And we did the best we could. We put our best foot forward in trying to get that geographic diversity and like the rural versus urban, and we realize that that's a limitation to the findings. Avik, I don't know if you have anything else you want to say about that.
No, I think that's all good. I think that we are increasingly recognizing in the space as substance use and addiction researchers that we need to support people. I mentioned this in the chat, but if we're asking to partner with you, that we can't just sort of come into your space. I think Tom was a fantastic, I'm not saying, I think Tom was probably like a breath of fresh air in a lot of these spaces, coming in with his donuts and all that stuff. But it is a burden, right, to have to give up a room or to have staff have to direct a new person around and all that stuff. So figuring out best practices that do involve supporting our community partners rather than just sort of asking for time and things and not giving back. So that is something we're working toward being better at. But yes, I agree, Western Mass, that was the goal. At that point, we didn't have the sort of connections, I think, and to make it happen. And again, folks are busy, so we don't want to, we can't generate time out of nowhere and those resources that are nowhere. But that's a future goal for sure for future studies.
Great, thank you. There are some, Mattie, did you have something?
Yeah, I just wanted to ask about the date sheet, to keep the names of the folks that were probably perpetrators. I think one of my questions was when I asked about that it affects people's ability to privacy. So that if we have something like that we're disturbing people's privacy, and how did something like that come about, and is that appropriate to say that we're everybody has their privacy? I don't know if yeah, Tom.
I'm happy to answer part of that, Des, too. I'd let you piggyback off if I miss anything, but I think the idea is that my first introduction to a bad date list was when I worked at like the University District Needle Exchange here in Seattle, and so would have participants come up and mostly women, mostly femme-identified folks, trans femmes, femme-identified folks who are saying like, I want, can I add something to the list? I had this experience happen to me, this morning or last night or in the last week, and I'm trying to help protect my community of other folks who are in this life that I am, to prevent the same thing from happening to them. And so, there's confidentiality in so far as that you don't need to disclose who you are when you're wanting to add an experience that you're having to the bad date list. And then the only, identifying factors that are happening for the people described in the bad date list, it's like, that is so, they're being identified as folks who are bad actors, doing things that are harming, sometimes really severely harming other people. And so it's not, it's not like doxing them or anything like that. It's more just kind of like, look out for this person. This is the kind of car they drive. These are the types of things that they're going to say to you when they're asking you for a date. They wear these clothes. They frequent this area. If this is some of their physical descriptors, maybe a birthmark here, this type of facial hair, etc. And if you're in contact with that person, just know you're at higher risk of something really scary and violent or harmful happening to you. So I think that's kind of how I think about the confidentiality piece there. I don't know, Des, do you have anything else?
Yeah, no, I would agree with that. It's if somebody ends up on the bad date list, there is something ultra terrifying that happened to them, because the reality is there's no good dates. There's no good, you know what I mean? So it's something that probably could cause significant harm. I think most sex buyers don't deserve privacy anyway, but let's pretend they did for the sake of this conversation. Most of them aren't there out using their real names. It's a lot of like what Tom said, just like identifying things and, you know, what may have been experienced so that the other women don't end up in that same position.
Thank you.
Thank you.
Thanks for bringing that up. We're sort of coming to a close, but I don't want to forget about our young people, young adults and families. And there's been a couple of questions around that. Alice Colgrove specifically, who has spent many years serving homeless and unsheltered young adults, and is asking the panelists or the researchers if you have any recommendations for serving young adults who use drugs and making spaces more welcoming for them.
One thing I didn't
So-
mention, I think in my initial response was that, healthcare for the homeless and our family team, we have a specific youth outreach van. So the mobile van that some of you may know about, the craft supported van, there's a specific session that's dedicated to youth and young adults. And not only is the mobile approach, but actually the mobile approach linked to social media. That team has found that having an Instagram account, I actually don't know if they have TikTok now, but was a really helpful way to connect with folks. And so even folks that wouldn't stay at Y2Y or wouldn't stay at Bridge Over Troubled Waters, which are 2 shelters for youth and young adults, they might message and say, I need some, XYZ, Narcan, whatever it is, and the van would go there and drop stuff off. And so the social media piece is really important, I think, in particular. And I think the mobile piece is important if you don't have sites that are specifically dedicated to youth and adults, as far as getting harm reduction supplies out there.
Great. Any of the panelists want to add into kind of considerations for young adults, or? And that's okay if not. Thank you.
Avik kind of pointed at it too, but in this work is kind of an example of the cross sections between public health and addiction medicine, and also the homeless response system, the crisis response system, and homeless services. And I think that a really critical and important piece for COCs is just the youth action boards. So getting that youth voice. The youth with lived experience talking about their experiences, seeking services and receiving services, and how well or not well that went for them. So just wanting to uplift the power of YABs, as they're called, youth action boards, and their ability to influence and impact policy and services for them. So.
Great. Okay, so we are coming to the conclusion. I would just ask, give the opportunity for any of our panelists or researchers, or Dr. Castiel, if you wanted to share any last thoughts before we conclude. I open it up to you. Our appreciation for you being here today and bringing your experiences, but anything as far as this session goes that you want to say to the group?
I think I learned a lot of it. I look at, I think we have a long way to go, I should say, at least in some of the shelters. You showed models of care. I don't think every shelter has it. So I think bringing these conversations to talk about it is incredibly important, and for others to see that this is what we should be doing and what is expected. And I think about all your conversations, Mario, with humanity, and how do we bring that humanity, and how do we have those relationships with people, and what is our role in the shelter is incredibly important. I certainly feel it, and I feel it here in the city, hoping that we could implement a lot of what you guys brought up today. So truly impressive. So thank you.
Okay, so thank you so much, Tom, Avik, Mario, Greg, Desiree, and Dr. Castiel for joining us today. Certainly everyone that did join us, we had people are starting to fall off now, but we had upwards of 300 plus participants. We're so excited. I think we need to continue to reach out, to your point, Dr. Castiel, to bridge the harm reduction and shelter communities together. Sort of federally and statewide, these are kind of still two separate systems, and we really need to sort of reach out to pull our shelter providers in with our sort of harm reduction folks. And we'll continue at RIZE to prioritize that, to continue to have this conversation with all of you and others, as that's what we love. It's what we love to do, is sort of keep the discussion going and sort of pushing the limits. So I just wanted to extend the thanks to all of you and to everyone that joined us today. And we will be sending up a follow-up email. Please take the post-webinar evaluation survey. It's so important to us as we do events like this to learn from. And we will, as I said before, circulate the published harm reduction shelters toolkit that resulted from Tom and Avik's research, and hope that it'll be very useful to folks. It will be, well, I think it's already posted on our website. And please stay in touch with RIZE. Learn more about us by following us on Twitter and LinkedIn, and subscribing to our newsletter at rizema.org. And we really appreciate everyone's time today. Thank you so much for the support, and have a great day.
Thank you, everybody.
Thank you.
Thank you.